This video demonstrates a case of recurrent right inguinoscrotal hernia following mesh explantation, and I managed with a T-tape approach. You can see the CT scan. A large recurrent right inguinoscrotal hernia was there because of the previous open surgery. You can see the open scar mark on the right groin, and also there was a primary left inguinal hernia. So it's a bilateral inguinal hernia. So I've started to gain the retrorectus access on the left side using OptiView technique. So layer by layer penetration, and now I'm in between the rectus muscle above and the posterior rectus sheath below. So after creating some pneumopressure, so further dissection was to create and enlarge the retrorectus space using hook dissection. So after putting one port in the left upper abdomen in the retrorectus plane, I have placed one more port lower down below the level of the umbilicus medial to the linea semilunaris, and tried creating further space using hook. So once a little bit of space has been created, so I've changed my camera from 10 millimeter 0 degree to 5 millimeter 30 degree and put the camera in the lower port, and using hook from the upper port, initial OptiView port, creating further space to do the lower midline crossover. So you can see just dividing the posterior rectus sheath just below the linea alba to gain access onto the preperitoneal space on the right side and onto the lower down. So you can see the right posterior aspect of the right posterior rectus sheath and the arcuate line here, and then lower down I have created further space gradually, safeguarding the inferior epigastric vessels. So these are the midline fats, preperitoneal fats that were brought down, and I have kept one more port, maintaining the triangulation in the laparoscopic technique and at the level of the umbilicus. So this is the midline, and you can see they have exposed the pubic arch. So that is a space of radius a little bit created, and then coming onto the lateral side and just lateral beyond the inferior epigastric vessels. This is the posterior rectus sheath which is going up to the linea semilunaris, and just below that I am just dividing the posterior rectus sheath on the lower down aspect to gain access into the space of Bocros on the right side. So now you can see once I have divided and a little bit of further division will help me to gain access into the space of Bogros, and it is gradually created. So idea is to create space all around the defect area, and then I'll be targeting the hernial sac. So medial space, lateral space is medial space is getting created, lateral space is created a little bit, and then I'll be creating further space. So the hernia was large, but it was reducible, and actually the patient underwent open right inguinal hernioplasty 3 years back, and following which there was mesh infection, and the mesh was explanted 6 months following the primary surgery, and following which gradually he developed recurrent inguinoscrotal hernia, and it has increased in size. So according to the CT scan, there was a 4 centimeter defect on the right groin, and on the left side there was a 1.5 centimeter defect on the left groin. So these are the defect measurement. So in this kind of recurrent groin hernias, what we need to plan is here to have enough space all around the defect, because this there will be additions of the sac with the incision line, and you want at certain point of time after dissection all around the sac, we need to divide the sac, because otherwise we won't be able to bring down the whole sac from the scrotum, because it's the and it was not needed actually. So once I have created enough space towards the defect area, I will be dividing the sac. So the distal sac will atrophy with time, and this is the proximal sac which I am dissecting, and then I will be incising to divide the sac at this point, at the point of internal ring. So you can see I'm using a good amount of traction, and with my left hand instrument, and using Maryland forceps with monopolar energy, I have started dividing the sac. it was a big defect, so the hernial sac margin was also big. So but you can see the inside of the peritoneal cavity, now the bowel. So while dividing, you have to safeguard, you have to take care of the intra-abdominal content, so that the no transmission of energy is done onto the bowel or bladder. So little bit of division of the sac, and then a dissection to identify the proper plane of division, and then gradually the circumferential, the 360-degree division should be done. So here in the front aspect of the sac, there is no vital structure, but the when we will be going towards the back of the sac, there will be cord structures, the vas deferens gonadal vessels, so that we should take care of. And while dividing on the upper aspect, the inferior epigastric vessel should not be injured. So you can see very gently I am just trying to dissect and try to identify the margin, and then gradually using little bit of cautery at a time, and dividing the sac all around, so almost reaching up to the circumferential dissection of the division of the sac. So here you can see, so the small vowel can be seen over there. So just staying above and trying to identify which plane to follow. So as this is a recurrent inguinal hernia and it's a big one, there will be external pulling of the sac while you will be doing the dissection. You will feel there is external pull because of the pneumo pressure, but good amount of traction from inside. And also you can ask your scrub nurse to put pressure from the outside, so that you can manipulate the sac nicely. If needed, you can put one extra port for giving assistant traction with the assistant traction for the sac, so that you can divide the sac nicely. So here in this case I didn't use the extra port at this point of time. This sac was almost dissected, safeguarding the gonadal vessels. Now I am reflecting the gonadal vessels towards the parietes. Now I'll be able to see this is the margin of the sac, so complete division of the sac has been done. And these are the gonadal vessels which I'll be separating. Now you'll be able to understand, these are the gonadal vessels that I am separating with my Maryland forceps, and the vas deferens also visible. So because of the previous surgeries twice in the groin, open surgeries twice in the groin, so open inguinal hernioplasty followed by open mesh explantation, the anatomy will be a little bit distorted. So abdominal, along with the defect, large defect in the indirect inguinal hernia area, there is also a pulling of gonadal vessels and the vas deferens towards the defect. So safeguarding both the structures, I'll doing the parietalization. So once I'm beyond the defect margin, I'll be doing the parietalizations to bring the release the peritoneum from the cord structure, so that I can achieve the critical view of myopectineal orifice nicely. So you can see this is in continuation of the achieving myopectineal orifice. Parietalization of the sac. Now you can see the divided margin of the sac, the gonadal vessels, the vas deferens can be easily, lateral is the gonadal vessels, medial is the vas deferens. So the both of them are safeguarded. Now I have started, I have taken a 3-0 V-lock suture to close the peritoneal rent. So as this is a eTEP approach, there is enough space, even though there is a large hole in the peritoneum, the space is not getting obliterated, as you can see. And that is the advantage of eTEP approach for this kind of large inguinoscrotal hernias. So because you are creating enough space in the below the umbilicus, so that even if you have done a rent in the peritoneum, you won't be losing that much of space like we tend to lose in a general TEP approach. So that is the idea of choosing eTEP repair for this large inguinoscrotal hernia. So other option could have been a bilateral tap repair, but bilateral tap, rather than doing bilateral tap, I have decided to do a eTEP approach. I generally don't do eTEP for inguinal hernias because I personally my personal preference is to do Palanivelu's triangulation technique of TEP approach that will help me to do bilateral dissection nicely. But this is the first time I'm using an eTEP approach for groin hernia, and particularly for this particular case where this is I anticipated prolonged dissection and complicated dissection. So now, after repairing the peritoneal rent, I am creating further space of ridges on the lateral side. You can see the psoas muscle and the overlying dulux fascia, which are covering the nerves, the gonadal vessels, the vas deferens. So further dissection of the further releasing of the peritoneum from the cord structures, you can see, to create adequate space all around the defect. So I can place a large mesh. In this case, I will be using larger mesh that I routinely use for inguinal hernias. Routinely I use a bar 12 by 15 centimeter mesh. In this case, I will be using a 12 by 18 centimeter mesh. And this is an important step of this kind of recurrent inguinal hernias, the large recurrent inguinal hernias where there is a big defect more than this defect is more than 3 centimeters, so around 4.1 centimeter defect as per CT scan. So although it's an indirect hernia, I have decided to partially narrow down the defect using a non-absorbable V-lock suture. This is a 10 V-lock suture, non-absorbable. So start it from the lateral end. I am taking the arch fibers and the iliopubic tract. So it's like a iliopubic tract repair that we do in pediatric hernias. So same like where I will be taking bites from the arch fibers and the hernial sac area and the iliopubic tract. So while taking the bites, we should take care that there should not be any injury to the any important nerves or vessels. So that can cause some bleeding or the postoperative pain. So that suturing is important to narrow down the defect. Here you can see now I have narrow down the defect, but there should not be any tight closure so that it can impinge upon the cord structures. That should be taken care. So once it is done, so for left inguinal hernia also I have kept one port, that fourth port was kept on the right side, and now I've changed my camera to the umbilical port side, and with using right and left hand port I'll be doing the left groin dissection. So here there was a direct hernia, you can see. So this is a direct hernia, the preperitoneal fat which was going through the left sided direct defect. This is a pseudo sac I am getting reduced, and the further dissection will expose the Cooper's ligament on the left side also, and at least below the Cooper's line at least 2 to 3 centimeter we should dissect. And again on the left lateral aspect, I am dividing the posterior rectus sheath lower down so that I can get into the lateral space of Bogros on the left side. So here you can see the bringing down, pushing down the peritoneum. I'll be creating further space in the space of Bogros on the lateral aspect. Here you can see nicely the space is getting created, and further dissection towards the indirect defect area, I found there was a cord lipoma was there. So again, in any particular inguinal hernia repair, we should always look for a presence of cord lipoma, and that should be dissected off. Otherwise, there is a chance of postoperative persistent bulge in the groin area. So now I'll be pulling the cord lipoma towards the dissection area. You can see good amount of traction with the left hand instrument, and then with the hook and monopolar energy I'm dissecting it off from the cord structures. So you have to differentiate between the two things. One is cord lipoma and one other is fatty cord. So sometimes cord structures are engulfed with or entangled with fatty tissues. So Sometimes we tend to confuse whether it's a cord lipoma or a fatty cord structures. So that we have to differentiate while doing the dissection. In case of cord lipoma, we should dissect it off, but in case of fatty cord structures, we should not dissect, because while dissecting those fatty fiber fatty tissue, we may injure the gonadal vessels or the vas deferens. Now further dissection proceeded to expose the myopectineal to expose the cord structures and achieve the myopectineal orifice. So you can see further dissection on the medial aspect, the preperitoneal fiber fatty tissue is dissected off. Now the medially the vas deferens, laterally the gonadal vessels are getting properly visualized, and the beyond that the external iliac vein is also visible. Laterally the dulux fat, which is covering the psoas muscle, and then a lot of important nerves is exposed. So I am doing a further lateral dissection to expose the lateral space of Bogros more enough to put a large mesh in this area also to cover the all the potential hernia defect nicely with adequate mesh overlap. And you can see, so at least from the defect margin the sac should come down at least 5 to 6 centimeter. And now medially in the midline the preperitoneal fat is exposed, so that I can expose the symphysis pubis, and I can go beyond that, so that at least 2 to 3 centimeter below the Cooper's ligament I can expose. Finally checking for the hemostasis. So the complete dissection has been done. Now this is the left indirect hernia, direct hernia, and right sided large recurrent indirect inguinoscrotal hernia. So three hernia defects were there. One was repaired. Other defects on the left side were small, so we left as it is. So now on the right side I have placed a 12 by 18 centimeter medium weight fat polypropylene mesh, as I have created enough space to place a big mesh. Once I have after placing the mesh, I have unfolded the mesh. It will sit nicely over that area, covering all the potential hernia sites. Now you can see the lower outer and lower corner of the mesh, placing it nicely without any folding is very important. So you can see all the margins of the surrounding margins of the mesh should be lying flat, and there should not be any undue folding of the mesh, nicely sitting. Also the left mesh 12 by 15 centimeter regular that I use for groin hernias was placed. There is a 12 by 15 centimeter medium weight polypropylene mesh, and that is also sitting nicely. Now what I will do is, because that was a recurrent case, so I will be fixing the mesh. This is 30 V-lock suture, absorbable V-lock suture. What I am doing at the midline and the lower abdomen midline, I am taking one bite to include both the meshes in the and fixing it with the rectus abdominis. So as these barb suture, I am taking two bites and keeping like that, so that will keep the mesh in that position till it gets fixed. So that is one fixation. And there is another fixation for the right sided mesh, the bigger mesh for the bigger hernia that I have placed. The upper outer corner of the mesh was fixed with the lateral abdominal wall muscles, and that should not be too tight. It's known as a floating stitch, so that or anchoring stitch, so that it will keep the mesh at this position. So now the mesh fixation is done, the hemostasis is checked, and gradually deflate the pneumoperitoneum. The patient was absolutely fine in the postoperative period, mobilized within 4 hours, so walking around, and discharged on the postoperative day 1. Thank you.